The rate of ILD on trastuzumab is an interesting question, since certainly it appears that antibodies can cause very low rates of interstitial lung disease. We actually have been fortunate not to see any symptomatic ILD at our institution, and I haven't seen a patient who's had symptomatic ILD from trastuzumab. Certainly, I have from radiation and taxanes and other agents, but not from trastuzumab. And what we do see is more a grade 1 pneumonitis that shows, or ILD that shows up on a CT scan, where you're trying to figure out whether or not this is related to drug or, as I mentioned, some other benign cause. And the other option, of course, is to understand whether people have lymphangitic spread of their cancer. And so we're always trying to evaluate this and take a closer look at lung findings in order to try and understand whether or not a change on scan in a relatively asymptomatic patient could potentially be related to drug. In an asymptomatic patient, you have in some ways, luxury to follow them. I think that with newer agents, we have to really decide what the suspicion is and whether or not we should be holding drug in the metastatic situation in order to clarify what is actually going on in the lung. In patients who are symptomatic, many times the I think challenge that's posed to the oncology team is understanding whether or not this is disease or drug related, and that is it's really a critical differentiation where I think that we need to be holding drug if we have a suspicion and trying to sort out what's going on rather than continuing to treat. Oncologists generally perform the main monitoring for ILD. It might be different in institutions that are cancer only, but we certainly wouldn't refer a patient to a pulmonologist for monitoring, detection of ILD. If a patient develops significant respiratory symptoms, we would partner with pulmonology in order to manage the ILD. And I think that this kind of partnership is really important for our patients. It's important to keep in mind that no matter which agent we're looking at in terms of ILD, the actual incidence of symptomatic ILD has been relatively low. Recently, we have seen a slight uptick in terms of the incidence and risks associated with TDXD or DS8201, trastuzumab deruxtecan. And I think that that has made us much more aware of the fact that we should be monitoring on our own as oncologists and really take a earlier aggressive approach to both monitoring and management. For monitoring parameters, I think that there are two important aspects. One is that we monitor patients with regular scans who are on agents that are associated with ILD. And that's important because, patient who's been stable for a little while or doesn't have pulmonary findings in terms of their site of cancer might not have scans that include their lungs. Maybe you're doing more focused scans, or you might wait some period of time because their tumor markers are improving and their symptoms resolved. But if you know that a drug is associated with a risk of ILD, it's really important that you do get some kind of regular imaging in order to evaluate for ILD. The second thing is that if a patient has a symptom, for example, has an upper respiratory infection and a cough, as my patient who's been on trastuzumab deruxtecan for the longest period of time has had, she has a small child at home, she would come in with these very nonspecific symptoms, and I always get a chest x-ray. Thankfully, it's not very frequently, but I have reinforced the need to report these symptoms continuously with that patient, and also our nurses and triage staff also do. So I think there are several aspects of it for monitoring. One is monitoring the tumor and including that in a way of assessing ILD. The second is a much earlier assessment of the lungs in patients who have relatively mild symptoms. And the third is really both patient and staff education about really jumping on a symptom if a patient calls in rather than waiting and saying, call me if it gets worse. It's a great question. Is there a class effect among ADCs that we're going to be seeing interstitial lung disease? And I don't necessarily believe that that's true because we haven't seen it with all of the ADCs, but I would keep in mind that for a rare toxicity, it might take a very long time to really understand that a drug is associated with ILD. we use these agents to treat advanced disease. Patients have a number of different risk factors for ILD, and also they have metastatic cancer. So they may have a lot of things that are confusing the appearance of what's going on if patients develop progressive pulmonary symptoms. So I do think that we don't know the answer to whether this is a class effect among ADCs fully yet. But I will say that the risk, if there is a risk with all ADCs, it's going to be very low. There are some agents where there is a class effect, but the incidence varies a lot between the agents. For example, oral tyrosine kinase inhibitors, where we've seen ILD be reported with many different agents, and there does appear to be some class effects. For ADCs, I think it's a lot more complicated because it's not necessarily associated with the A, the antibody, but more the D, the drug conjugate. So it may be that you need a specific drug that could cause has a higher risk of ILD and is released. So you need a higher density of drug potentially on the ADC to see this, and you need a specific drug that can be associated with inflammatory changes in the lung. So I think that the jury is generally out, but it's not clear that all ADCs cause ILD. Of course, anytime that we see a toxicity with a specific drug or even a class of drug, we're very interested in understanding if there are patient factors that make someone at greater risk for developing ILD. And it's interesting because COVID-19, which of course has been on much of our minds in 2020, we also know that most people get this infection and they don't die of respiratory failure. And then some people get very peculiar symptoms like loss of smell and other people don't. So we already know just the flu, if you think about it, there are deaths from the flu every year, but it's very rare to die of the flu. So we already know that for anything that affects the lung, and certainly for infectious agents, that there are patient risk factors that we really do not understand well at all, although there's been certainly a great attempt with COVID-19. For these antibody drug conjugates and for other agents that say the oral tyrosine kinase inhibitors, even taxanes, really it requires a fair amount of experience to understand what potential risk factors could be. And I think there will always be an individual risk factor that we don't understand that may be associated with pharmacogenomics or particular sensitivity in the lung. What we do know is that having cancer in the lung, whether it's pleural pulmonary disease in nodules or lymphangitic spread, does not appear to increase your risk of developing ILD. We don't radiate the lung much with breast cancer. We try and avoid the lung when we're radiating breast. But it is possible when we have more cases and are better able to associate risk factors that prior radiation that included a larger lung field, for example, radiating the internal mammary nodes might place a patient at risk, but we don't really know that now. It has placed patients at risk for pneumonitis associated with taxanes when patients have had a greater amount of lung radiated, and the same is true of lung cancer. So I think that that's an area of great interest. It would also be, I think, interesting to understand whether patients who smoke or, really with horror vape, which clearly puts your lungs at huge risk for inflammation and what is essentially ILD. So these are the kinds of factors that we're really going to be having to look at. Again, we haven't really been able to associate this with age, diabetes, obesity, the kinds of things that we've looked at for risk factors with COVID-19, for example. And I suspect that it will take larger phase 3 trials and more time to try and flesh this out specifically so that we know who to monitor more closely.